Hello everyone, and welcome to another stream of Advanced Pharmacology. Today we're talking about Chapter 47, Drugs for Thyroid Disorders. Thyroid hormones have profound effects on metabolism, cardiac function, growth, and development. These hormones stimulate the metabolic rate of most cells and increase the force and rate of cardiac contraction. During infancy and childhood, thyroid hormones promote maturation. Severe deficiency can produce extreme short stature and permanent mental impairment. Fortunately, most abnormalities of thyroid function can be effectively treated. We begin our study of thyroid drugs by reviewing thyroid physiology. Next, we review the pathophysiology of the hypothyroid and hyperthyroid state. Finally, we will discuss the agents used for thyroid disorders. So, thyroid physiology, chemistry, and nomenclature. The thyroid gland produces two active hormones, the triiodothyroid and thyroxine, so T3 and T4. These hormones have nearly identical structures. The only difference is that T4 contains 4 atoms of iodine, whereas T3 contains 3. The biologic effect of T3 and T4 are qualitatively similar. However, when compared on a molar basis, T3 is much more potent. Preparations of T3 and T4 employed clinically, although synthetic, are identical in structure to the natural occurring hormones. The generic name of synthetic T3 is leothyronine, and the generic name of synthetic T4 is levothyroxine. A fixed ratio mixture of T3 plus T4 is known as Liotrix, and that is also available. So that brings us to the synthesis and fate of the thyroid hormone. Synthesis. Synthesis of thyroid hormones takes place in 4 steps. And you'll see those 4 steps more closely in figure 47.1. The circled numbers in the figure correspond with these steps. Step 1. The formation of the thyroid hormone begins with the active transport of iodide into the thyroid. Under normal conditions, this process produces concentrations of iodide within the thyroid that are 20 to 50 times greater than the concentration of iodide in plasma. When plasma iodide levels are extremely low, intrathyroid iodide content may reach levels that are more than 100 times greater than those in the plasma. Step 2. After uptake, iodide undergoes oxidation to iodine, the active form of iodide. Iodide oxidation is catalyzed by an enzyme called peroxidase. Step 3. In this step, activated iodide becomes incorporated into tyrosine residues that are bound to thyroglobulin, a large glycoprotein. One tyrosine molecule may receive either 1 or 2 iodide atoms, resulting in the production of the monoiodotyrosine, or MIT, or the diiodotyrosine, or DIT, respectively. Step 4. In the final step, iodinated tyrosine molecules are coupled. Coupling of the DIT with one MIT forms a T3. A coupling of one DIT with another DIT forms T4. So here is a picture of that very explanation. So if you're unfamiliar with your pathophysiology, it's a good spot to pause and just take a look and review. Which brings us to fate. Thyroid hormones are released from the thyroid gland by a proteolytic process. The amount of T4 released is substantially greater than the amount of T3 released. However, much of the T4 that is released undergoes a conversion to T3 by enzymes in peripheral tissues. In fact, conversion of T4 to T3 accounts for the majority, about 80%, of the T3 found in plasma. More than 99.5% of the T3 and T4 in plasma is bound to plasma proteins. Consequently, only a tiny fraction of circulating thyroid hormone is free to produce biologic effects. Thyroid hormones are eliminated primarily by hepatic metabolism. Because T3 and T4 are extensively bound to plasma proteins, metabolism is slow. As a result, the half-life of these hormones are prolonged, about 1 day for T3 and 7 days for T4. Thyroid hormone actions. So what do? The thyroid hormones have three principal actions: the stimulation of energy use, stimulation of the heart rate, and the promotion of growth and development. The stimulation of energy use elevates the basal metabolic rate, resulting in increased oxygen consumption and increased heat production. Stimulation of the heart rate increases both the rate and force of contraction, resulting in increased cardiac output and increased oxygen demand. Thyroid effects on growth and development are profound. Thyroid hormones are essential for normal development of the brain and other compartments of the nervous system, and they have a significant effect on the maturation of the skeletal muscle. Thyroid hormones produce their effect by modulating the activity of specific genes. Furthermore, it appears that most, if not all, of the effects of thyroid hormones are mediated by T3, not by T4. There's a good evidence that T3 penetrates to the cell nucleus and binds with high affinity to nuclear receptors, which in turn bind to specific DNA sequences. The result is the modulation of gene transcription, causing production of proteins that mediate thyroid hormone effects. Although T4 also binds with nuclear receptors, its affinity is low, and gene transcription is not altered. Hence, it would seem that T4 serves only as a source of T3, having little or no physiologic effect of its own. The regulation of thyroid function by the hypothalamus and the anterior pituitary. The functional relationship between the hypothalamus, anterior pituitary, and thyroid is shown in the following figure 47.2. As indicated, thyrotropin-releasing hormone, or TRH, secreted by the hypothalamus, acts on the pituitary to cause secretion of the thyrotropin, your thyroid-stimulating hormone, or TSH. TSH then acts on the thyroid to stimulate all aspects of thyroid function. Thyroid size is enlarged, iodine uptake is augmented, and synthesis and release of thyroid hormones are increased. In response to rising plasma levels of T3 and T4, further release of TSH is suppressed. The stimulatory effect of TSH on the thyroid, followed by the inhibitory effect of thyroid hormone on the pituitary, constitutes a negative feedback loop. So here is a picture of the regulation of the thyroid hormone. Another good spot to hit pause just to kind of take a look and review. Effects of iodine deficiency on thyroid function. When iodine availability is diminished, production of thyroid hormones decreases. The ensuing drop in thyroid hormone levels promotes release of TSH, which acts on the thyroid to increase its size, causing a goiter and ability to concentrate iodine. If iodine deficiency is not too severe, the increased capacity for iodine uptake will restore normal production of T3 and T4. So that leads us to the thyroid function test. Several lab tests can be used to evaluate your thyroid function. Three are described here. The values indicating euthyroid or normal, hypothyroidism or low, and hyperthyroid states. Again, a good spot to hit pause to kind of familiarize yourself with what our lab values should be. So, serum thyroid stimulating hormone test. Your serum TSH determinations are used primarily for screening and diagnosis of hypothyroidism and for monitoring replacement therapy in hypothyroid patients. Measurement of serum TSH is the most sensitive method for diagnosing hypothyroidism because the anterior pituitary is exquisitely sensitive to changes in thyroid hormone levels. As a result, very small reductions in serum T3 and T4 can cause dramatic rise in serum TSH. Therefore, even when the degree of hypothyroidism is minimal, it will be reflected by an abnormally high level of TSH. When replacement therapy is instituted, the TSH level should return back to normal. Serum TSH determinations can also be used to distinguish primary hypothyroidism from secondary hypothyroidism. So, in primary hypothyroidism, your TSH levels are high. However, in your secondary hypothyroidism, the TSH levels are low, normal, or even slightly elevated, despite the presence of low levels of T3 and T4. And that is primarily because in your secondary hypothyroidism, the hypothyroidism results from an anterior pituitary dysfunction, while in your primary, it's thyroidal. Serum thyroxine tests. Testing can measure either the total T4, bound plus free, or just a free level of T4. Measurement of free T4 is preferred. The T4 test can be used to monitor thyroid hormone replacement therapy and to screen for thyroid dysfunction. However, in both cases, the measurement of TSH is preferred. Your serum triiodothyronine test. As with the T4 measurement, we can measure either a total or a free T3. Measurement of free T3 is preferred. This test is useful for diagnosing hyperthyroidism. In this disorder, levels of T3 often rise sooner and to a greater extent than do levels of T4. T3 determinations can also be used to monitor thyroid hormone replacement therapy. All thyroid preparations should increase levels of T3. So that brings us to the pathophysiology. Hypothyroidism. Hypothyroidism can occur at any age. In adults, mild deficiency of thyroid hormone is referred to simply as hypothyroidism. Severe deficiency is called myxedema. When hypothyroidism occurs in infants, the resulting condition is called congenital hypothyroidism. So, we'll start off with hypothyroidism in adults. The clinical presentation. Your signs and symptoms of hypothyroidism depend on the disease severity. With mild hypothyroidism, symptoms could be subtle and may go unrecognized for what they are. In contrast, with moderate to severe disease, characteristic signs and symptoms emerge. The face is pale, puffy, and expressionless. The skin is cold and dry. The hair starts to become brittle and hair loss occurs. Heart rate and temperature are lowered, and the patient may complain of lethargy, fatigue, and tolerance to cold. Mentation may be impaired. The thyroid enlargement may occur if reduced levels of T3 and T4 promote excessive release of TSH. So, what would cause this? Well, in hypothyroidism in the adult, it's usually due to a malfunction of the thyroid itself. In iodine sufficient countries, the principal cause is chronic autoimmune thyroiditis, also known as Hashimoto thyroiditis. Other causes are insufficient iodine in the diet, surgical removal of the thyroid, and the destruction of the thyroid by radioactive iodine. Adult hypothyroidism may also result from insufficient secretion of TSH and TRH. So, the therapeutic strategy behind hypothyroidism in adults requires replacement therapy with thyroid hormones. In almost all cases, treatment must continue lifelong. Today, the standard replacement regimen consists of levothyroxine, T4 alone. Combined therapy with levothyroxine plus liothyronine is also an option. However, with only three exceptions, all studies to date indicate that combined T3-T4 offers no advantage over a T4 alone. Remember, when we give T4, much of it is rapidly converted to T3, and the active form of the hormone. When replacement doses of T4 are adequate, they can eliminate all signs and symptoms of the thyroid deficiency. Hypothyroidism, however, during pregnancy. Maternal hypothyroidism can result in permanent neuropsychological deficits in the child. We have long known that congenital hypothyroidism can cause developmental problems. So we'll discuss that more under the hypothyroidism in an infant. However, it was not until 1999 that researchers demonstrated that maternal hypothyroidism in the absence of fetal hypothyroidism can decrease IQ and other aspects of neuropsychological function in the child. The effect of maternal hypothyroidism is limited largely to the first trimester, a time during which the fetus is unable to produce thyroid hormone of its own. By the second trimester, the fetal thyroid gland is fully functional, and hence the fetus can develop. Maternal hypothyroidism must be diagnosed and treated very early. Unfortunately, symptoms of hypothyroidism are often nonspecific. Again, it's irritability, tiredness, poor concentration, or there may be no symptoms at all. Accordingly, some authorities now recommend routine screening for hypothyroidism as soon as pregnancy is confirmed. If hypothyroidism is diagnosed, replacement therapy should begin immediately. When women taking thyroid supplements become pregnant, dosage requirements usually increase, often by as much as 50%. The need for an increased dosage begins between weeks 4 and 8 of gestation. Levels of at about week 16, it begins to drop and then remains steady until parturition. To ensure adequate hormone levels, some authorities increase T4 dosages by 30% as soon as pregnancy is confirmed. Further adjustments are based again on that serum TSH level, which should be monitored pretty closely. So that leads us to that hypothyroidism in infants. What kind of clinical presentations would they, show in hypothyroidism? Well, in newborns, it may be permanent or transient. In either case, congenital hypothyroidism can cause delay in mental development and derangement of growth. In the absence of thyroid hormones, the child develops a large and protruding tongue, a potbelly, and dwarfish stature. Development of the nervous system, bones, teeth, and muscles are impaired. So what would cause this then? Well, congenital hypothyroidism usually results from a failure in thyroid development. Other causes could include autoimmune disease, severe iodine deficiency, a TSH deficiency, and exposure to radioactive iodine in utero. So, our therapeutic strategy. Hypothyroidism in newborns requires replacement therapy with thyroid hormone. If treatment is initiated within a few days of birth, physical and mental development will be normal. However, if therapy is delayed beyond 3 to 4 weeks, some permanent disabilities will be evident, although the physical effects of thyroid deficiency can and will most likely reverse. In all children, replacement therapy should continue for 3 years, after which it should be stopped for 4 weeks. The objective is to determine whether thyroid deficiency is permanent or transient. If TSH levels rise, indicating thyroid hormone production is low, we know the deficiency is permanent, so replacement therapy should resume. However, If the TSH and T4 begin to normalize, we know that the deficiency was transient, and hence further replacement therapy may not be necessarily necessary. Which takes us now to the opposite end of the spectrum, hyperthyroidism. There are two major forms of hyperthyroidism, also known as Graves' disease and toxic nodular goiter, which was previously known as plumber disease. Of the two disorders, Graves' disease is more common. Your signs and symptoms of both disorders are pretty similar, however. The principal difference is that in Graves' disease, it may cause an exophthalmos, whereas toxic nodular goiter does not exist. So let's talk about Graves' disease. Graves' disease is the most common cause of excessive thyroid hormone secretion. This disorder occurs most frequently in women aged 20 to 40. The incidence in females is almost 6 times greater than that in males. So, what clinical presentation would these women then present with? Most clinical manifestations result again from an elevated level of thyroid hormone. The heartbeat is rapid and strong, and dysrhythmias and angina may develop. The central nervous system is stimulated, resulting in nervousness, insomnia, rapid thought flow, and rapid speech. Your skeletal muscles may weaken and atrophy. Metabolic rate is raised, resulting in increased heat production, increased body temperature, intolerance to heat, and skin that is warm and moist. Appetite is increased. However, despite increased food consumption, weight loss occurs if caloric intake fails to match the increased rate in the metabolic rate. Collectively, the above signs and symptoms are referred to as thyrotoxicosis. In addition to thyrotoxicosis, patients with Graves' disease often present with an exophthalmos. The underlying cause is an immune-mediated infiltration of the extraocular muscles and orbital fat by lymphocytes, macrophages, plasma cells, and mast cells, and the mucopolysaccharides. So again, what causes Graves' disease? The thyroid stimulation in Graves' disease is caused by thyroid-stimulating immunoglobulins, which are antibodies produced by the autoimmune process. Your thyroid-stimulating immunoglobulins, or TSIs, increase thyroid activity by stimulating receptors for TSH on the thyroid gland. That is, TSIs mimic the effect of TSH on thyroid function. TSIs are not responsible for exophthalmos. So it's treatment. Treatment for Graves' disease is directed at decreasing the production of thyroid hormone. The three modalities are employed. The first being pretty much straightforward, surgical removal of the thyroid tissue. The second being the destruction of thyroid tissue via radioactive iodine. And the third being the suppression of thyroid hormone synthesis with an antithyroid drug. So there's two that come to mind, the methimazole and propylthiouracil. Radiation is usually the preferred treatment for adults, whereas antithyroid drugs are preferred in younger patients. Beta blockers and non-radioactive iodine may also be used as an adjunctive therapy. So, why would you choose a beta blocker? Well, beta blockers suppress tachycardia by blocking beta receptors on the heart. Non-radioactive iodine inhibits the synthesis and the release of thyroid hormones. Because the exophthalmos is not the result of hyperthyroidism per se, this condition is not improved by lowering thyroid hormone production. If exophthalmos is severe, it can be treated surgically or with high doses of oral glucocorticoids. So that pretty much sums up Graves' disease. Now let's talk about the toxic nodular goiter, or plumber's disease. The toxic nodular goiter is the result of a thyroid adenoma. Clinical manifestations are much like those of Graves' disease, except exophthalmos is absent. The toxic nodular goiter is a persistent condition that rarely undergoes spontaneous remission. Treatment modalities are the same as for Graves' disease. However, If an antithyroid drug is used, symptoms return rapidly when the drug is withdrawn. Accordingly, surgery and radiation should provide long-term control and are often the preferred method. Thyrotoxic crisis, also known as the thyroid storm. Thyrotoxic crisis can occur in patients with severe thyrotoxicosis when they undergo major surgery or develop a severe intercurrent illness, so an infection or sepsis. The syndrome is characterized by profound hyperthermia, a temperature of 105 or higher, severe tachycardias, restlessness, agitation, and tremors, unconsciousness, coma, hypotension, and heart failure may ensue. These symptoms are produced by excessive levels of thyroid hormone. Thyrotoxic crisis can be life-threatening and requires immediate treatment. High doses of potassium iodide or a strong iodide solution can be given to suppress the thyroid hormone release. Methimazole is given to suppress thyroid hormone synthesis. A beta blocker is given to reduce the heart rate, and additional measures, including sedation, cooling, and giving glucocorticoids and IV fluids, may be used to treat thyroid storm. Leading us to thyroid hormone preparations. For the opposite now, and the hypothyroidism. Thyroid hormones are available as pure, synthetic compounds and as extracts of animal thyroid glands. All preparations have qualitatively similar effects. The synthetic preparations are more stable and better standardized than the animal gland extracts. As a result, the synthetics are preferred to the natural product. Properties of thyroid hormone preparations are shown here in the following table. The big one that you see most likely in the hospital setting would be the levothyroxine or levothyroid tablets. So let's talk about levothyroxine, T4. Levothyroxine or levothyroid or synthroid is a synthetic preparation of thyroxine, a naturally occurring thyroid hormone. The structure of thyroxine is identical to that of the natural hormone. Levothyroxine is the drug of choice for most patients who require thyroid hormone replacement. Consequently, levothyroxine will serve as our prototype for the thyroid hormone preparations. So, here you'll take a look at the prototype of drugs. So, for hypothyroidism, we'll talk about levothyroxine, and for hyperthyroidism, we'll talk about methimazole. The pharmacokinetics. Its absorption. Absorption of levothyroxine is reduced by food. Accordingly, to minimize variability in blood levels, levothyroxine should be taken on an empty stomach in the morning, at least 30 to 60 minutes before eating breakfast. The conversion to T3. Much of an administered dose of levothyroxine is converted to T3 in the body. As a result, levothyroxine can produce nearly normal levels of both T3 and T4. Hence, for most patients, there is no need to give T3 along with levothyroxine. Its half-life and plasma level. Because levothyroxine is highly protein bound, almost a pure 100%, but technically about 99.97%, the hormone has a prolonged half-life, about 7 days. From a clinical perspective, this long half-life is good news and bad news. The good news is that hormone levels remain fairly steady, even with once-a-day dosing, which makes levothyroxine well suited for lifelong therapy. The bad news is that it can take almost up to a month, or 4 half-lives, for plasma levels of the levothyroxine to reach plateau or steady state. As a result, onset of full effect is delayed. Its therapeutic use, therefore. Levothyroxine is indicated for all forms of hypothyroidism, regardless of its cause. The drug is used for the congenital hypothyroidism, myxedema coma, a simple goiter, and primary hypothyroidism in adults and children. Levothyroxine is also used to treat hypothyroidism resulting from insufficient TSH, secondary to a pituitary malfunction, and from insufficient TRH, secondary to hypothalamic malfunction. In addition, levothyroxine can be used to maintain proper levels of thyroid hormones after, after thyroid surgery, irradiation, and the treatment with antithyroid drugs. But with all good things, there come adverse effects. When administered in appropriate dosage, levothyroxine rarely causes adverse effects. With an acute overdose, thyrotoxicosis can result. Signs and symptoms again include that tachycardia, angina, tremor, nervousness, insomnia, hyperthermia, heat intolerance, and sweating. The patient should be informed about these signs and instructed to notify the prescriber if they occur. Chronic overdosage is associated with accelerated bone loss and increased risk for having atrial fibrillation, especially in the older adult. The loss of bone increases the risk for fractures. So, there are also some drug interactions. Drugs that reduce levothyroxine absorption include your histamine 2H2 receptor blockers, your proton pump inhibitors, Serafate, Questran, Colestipol, your aluminum-containing antacids, your Maalox or Mylanta, your Tums or Oscal, plus calcium supplements, iron supplements, magnesium salts, and orlistat. So, to ensure adequate absorption of Synthroid, patients should separate the administration of Synthroid with these other drugs by at least 4 hours. As noted earlier, food also reduces absorption, which is why you shouldn't eat while you're taking this medicine and take it about an hour before breakfast. Drugs that accelerate levothyroxine metabolism. So, the opposite end once more. This time, several drugs can accelerate metabolism of levothyroxine. Among these are dilantin, Tegretol, rivampin, Zoloft, and phenobarbital. Accordingly, to maintain adequate levothyroxine levels, patients taking these drugs may need to increase their levothyroxine dosage. Coumadin. Levothyroxine accelerates the degradation of vitamin K-dependent clotting factors. As a result, the effects of Coumadin are enhanced. If thyroid hormone replacement therapy is started in a patient taking Coumadin, the dosage of Coumadin may need to be reduced. Catecholamines. Thyroid hormones increases cardiac responsiveness to catecholamines, thereby increasing the risk for catecholamine-induced dysrhythmias. Caution must be exercised when administering catecholamines to patients receiving levothyroxine and any other thyroid preparation. And finally, other interactions. Again, Synthroid can increase requirements for insulin and digoxin. When converting patients from hypothyroid to a euthyroid state, dosages of insulin and digoxin may need to be increased. So, are levothyroxine preparations interchangeable? Levothyroxine is available in several brand name and generic formulations. Whether any of these are interchangeable, however, is in dispute. Levothyroxine has a narrow therapeutic range, so tight control of plasma drug level is important. Otherwise, symptoms of hypothyroidism or toxicity can and will develop. To maintain good control, all pills a patient takes must produce the same level of levothyroxine level. Accordingly, if a patient switches from one product to another, the new product must be bioequivalent to the old one. Whether or not any levothyroxine products, brand name or generic, are truly equivalent is a point of contention. According to the U.S. Food and Drug Administration, or FDA, certain formulations of levothyroxine are therapeutically equivalent to others. An example of this is the FDA maintains that generic levothyroxine made by Mylan is equivalent to two brand name products, Levoxyl and Synthroid. However, the three medical organizations, the American Association of Clinical Endocrinologists, the Endocrine Society, and the American Thyroid Association strongly disagree, as expressed in a 2004 position statement. They believe that the FDA's testing procedure was seriously flawed. First, the FDA only measured blood levels of levothyroxine, and they did not measure serum TSH, the favored clinical test for assessing thyroid status. Second, and more important, testing was done in normal volunteers. Hence, when blood levels of levothyroxine were measured, the values reflected the sum of endogenous thyroxine plus levothyroxine contributed by the drug, making it impossible to state with precision how much of the total was truly due to the drug. As a result, conclusions regarding the equivalence of levothyroxine products are questionable. Nonetheless, pharmacists may switch patients from one product to another, often without the knowledge of the patient or the prescriber, a practice with the potential for causing toxicity or therapeutic failure. Given the debate about whether certain levothyroxine products are clinically interchangeable, what should the clinician do? In their position statement, the AACE, the TES, and ATA recommend the following. The first being maintaining patients on the same brand name levothyroxine product. Second, if a switch is made from one branded product to another, or from a branded product to a generic product, or from a generic product to another, a retest serum TSH in 6 weeks and adjustment on the levothyroxine dosage is indicated. And lastly, to advise patients to check with their prescriber before allowing a pharmacist to switch to a different levothyroxine product. Bringing us to the dosage and administration general considerations. Routes of administration. Levothyroxine is almost always administered by mouth. Oral doses should be taken once daily on an empty stomach to enhance absorption. Dosing is usually done in the morning, at least 30 to 60 minutes before eating. Intravenous administration is used for myxedema, coma, or for patients who cannot take levothyroxine orally. Intravenous doses are about 50% of the size of oral doses, which requires special evaluation. The goal of replacement therapy is to provide a dosage that compensates precisely for the existing thyroid deficiency. This dosage is determined using a combination of clinical judgment and lab tests. When therapy is successful in adults, clinical evaluation should reveal a reversal of the signs and symptoms of the thyroid deficiency and an absence of signs of thyroid excess. Successful therapy of infants is reflected in the normalization of intellectual function and the normalization of growth and development. Monthly determinations of height provide a good index of success. Measurement of the serum TSH is an important means of evaluation. Successful replacement therapy causes elevated TSH levels to fall. However, TSH will not normalize quickly and often lags behind the normalization of serum T3 and T4. Hence, evaluation should not be done until 6 to 8 weeks after starting treatment. A TSH target of 0.5 to 2 microunits per ml is appropriate for most patients. When an adequate replacement dosage is established, TSH levels will remain suppressed for the duration of treatment. In some cases, serum T4 must be used to evaluate therapy because TSH secretions continue to remain high in some patients, even though levels of thyroid hormones have been restored to normal. When this occurs, Success indicated by levels of T4 in the normal to high normal range, whether or not TSH values are normal. So, the duration of therapy. For most hypothyroid patients, replacement therapy must be continued for life. Treatment provides symptomatic relief but does not produce a cure. Patients must be fully aware of the chronic nature of their condition. In addition, they should be forewarned that although therapy will cause symptoms to improve, these improvements do not constitute a reason to interrupt or discontinue drug use. Dosage and administration Part 2 Specific applications. Hypothyroidism in adults. When calculated on body weight basis, the average adult dosage is about 1.7 micrograms per kilogram per day. Most patients younger than 50 years can be started on full replacement doses, so about 100 to 125 micrograms per day for a 70 kilogram adult. For older patients, dosage should be low initially and then gradually increased. A typical starting dosage could be anywhere between 25 to 50 micrograms per day. For older adults with coronary heart disease, the starting dose is even lower, between 12.5 and 25 micrograms per day. Which brings us to myxedema coma. Myxedema coma is a rare but serious condition that requires rapid treatment. Levothyroxine is administered IV in a dose of 200 to 500 micrograms. If required, an additional dose of 100 to 300 micrograms can be given 1 day later. Glucocorticoids are also required. The glucocorticoid of choice is usually hydrocortisone. Congenital hypothyroidism. In congenital hypothyroidism, thyroid hormone dosages decrease with age. For infants younger than 3 months, the dosage is 10 to 15 micrograms per kilogram per day. For children aged 3 to 5 months, 8 to 10 micrograms per kilogram per day. And for children aged 6 to 11 months, 6 to 8 micrograms per kilogram per day. For children aged 1 to 5, 5 to 6 micrograms per kilogram per day. And for children aged 6 to 12, 4 to 5 micrograms per kilogram per day. In all cases, dosage is adjusted to normalize a TSH and free T4. Simple goiter. In simple goiter cases, the thyroid is enlarged and levels of thyroid hormones are reduced. Thyroid enlargement is caused by TSH that has been released in response to low levels of thyroid hormone. When treating simple goiter, the goal is to provide full replacement doses of thyroid hormones to suppress further TSH release. For many patients, this can be achieved with 100 to 200 micrograms of levothyroxine daily. Liothyronine, or T3. Liothyronine, or Cytomel, is a synthetic preparation of a tridothyronine, a naturally occurring thyroid hormone. The structure of liothyronine is identical to that of thyroid-derived T3. Because liothyronine is the active form of levothyroxine, the effects of the two drugs are identical. However, it does contrast with levothyroxine. Liothyronine differs from the levothyroxine in three important ways. The first being it has a shorter half-life and a shorter duration of action. The second being it is more rapid in terms of onset. And lastly, it is much more expensive. Because of its high price and the relatively brief duration of action, liothyronine is less desirable than levothyroxine for long-term use. However, because its effects develop quickly, liothyronine may be superior to levothyroxine in situations that require speedy results, especially with myxedema comas. Its evaluation, therefore, as with levothyroxine, the dosage of liothyronine is adjusted on the basis of clinical evaluation and laboratory data. Two laboratory tests are useful: free serum T3 and serum TSH. Because liothyronine is not converted into T4, plasma levels of T4 will continue to remain low. Hence, T4 levels cannot be used to assess treatment. Its dosage and administration. The usual route is oral, using cytomel, although dosing may also be done intravenously, using triostat. Oral dosage is about 80% of the dosage of levothyroxine. Because of its short half-life, oral liothyronine is taken twice daily, in contrast to levothyroxines, which is only taken once daily. Now there are some other thyroid preparations that we can utilize. Leotrix. Leotrix, or Thyroller, is a mixture of a synthetic T4 plus a synthetic T3 in a 4:1 fixed ratio. This ratio is similar to the ratio of these hormones in plasma. The rationale for using Leotrix is that the mixture can produce plasma levels of T4 and T3, similar to those that occur naturally. However, because levothyroxine alone produces the same ratio of T4 to T3, Leotrix offers no advantage over levothyroxine for most indications. Thyroid desiccated. Thyroid, armor thyroid, and others, consists of a desiccated animal thyroid gland. The standardization is based on content of iodine, levothyroxine, and liothyronine. The ratio of levothyroxine to liothyronine is not less than 5:1. Thyroid is available in tablets of 15 to 300 milligrams. For practical purposes, thyroid is obsolete. Use is limited to patients who have been taking the preparation for years. Thyroid is rarely prescribed for patients starting therapy today. So really it's an outdated practice that very few will continue to use at this time. So that was all for hypothyroidism. Now for drugs for hyperthyroidism. Your anti-thyroid drugs, your thionamides. The thionamides drugs, so your methimazole and propylthiouracil, or PTU, suppresses synthesis of thyroid hormone. These agents can be used long-term to treat hyperthyroidism, or short-term as a preparation for a subtotal thyroidectomy or therapy with a radioactive iodine. Methimazole and PTU are similar in most respects. Primarily, the difference between the two concern the pharmacokinetics that are described in Table 47.3 and the adverse effects of each medication. So looking at that table of 47.3, the pharmacokinetics of methimazole versus propylthiouracil. It's a good spot, again, as always, to hit that pause button. So you can look at the bioavailability, the plasma protein binding, levels in breast milk, the transplacental passage, half-life, initial therapy dosing, as well as maintenance dosing. So we'll start off with methimazole. Methimazole, or Tafazole, is the first-line drug for hyperthyroidism. Its benefits derive from inhibiting thyroid hormone synthesis. Methimazole is safer and more convenient than PTO, and hence is preferred for most patients, except women who are pregnant or breastfeeding, and perhaps patients who are in a thyrotoxic crisis. So those would be 3 indicators when it would not benefit. Its mechanism of action. Therapeutic effects result from blocking synthesis of thyroid hormone. 2 mechanisms are involved. First, methimazole prevents the oxidation of iodide, thereby inhibiting incorporations of iodide into tyrosine. Second, methimazole prevents iodinated tyrosines from coupling. Both effects result from inhibiting peroxidase, the enzyme that catalyzes both reactions. Please note that although methimazole prevents thyroid hormone synthesis, it does not destroy existing stores of thyroid hormone. Hence, after therapy has begun, it may take 3 to 12 weeks to produce a euthyroid state. Its pharmacokinetics, therefore. Methimazole is well absorbed after oral dosing. Binding to plasma proteins is minimal. The drug readily crosses membranes, including those of the placenta. Levels in breast milk are sufficient to affect the nursing infant. The plasma half-life is 6 to 13 hours, long enough to permit a once-a-day dosing. Its therapeutic effects and uses. Methimazole has 4 applications in hyperthyroidism. It can be used as the sole form of therapy for Graves' disease. It can be employed as an adjunct to radiation therapy until the effects of radiation become manifest. It can be given to suppress thyroid hormone synthesis in preparation for thyroid gland surgery, so a subtotal thyroidectomy. And lastly, it can be given to patients experiencing a thyroid toxic crisis. However, again, as all good things come, there are adverse effects. Methimazole is generally well tolerated, but should be avoided by women who are pregnant or breastfeeding. Granulocytosis is the most dangerous toxicity. The reaction is rare, only about 3 cases per 10,000 patients, and usually develops during the first 2 months of therapy. Sore throat and fever may be the earliest indications, and patients should be instructed to report these immediately. Because agranulocytosis often develops rapidly, periodic blood counts cannot guarantee early detection. If agranulocytosis occurs, methimazole should be discontinued. Agranulocytosis will then reverse. Treatment with granulocyte colony stimulating factors, so your filgrastim or Neupogen, may accelerate recovery. Hypothyroidism. When given in high doses, methimazole can convert the patient from a hyperthyroidic state to a hypothyroid state. If this occurs, dosage should be reduced. Temporarily, treatment with thyroid hormone may actually be required. So, its effects in pregnancy. Methimazole can cause neonatal hypothyroidism, goiter, and even congenital hypothyroidism. Accordingly, the drug should be avoided during the first trimester. Use in the second and third trimester is considered safe compared with the methimazole. PTO crosses the placenta poorly, and hence risk to the fetus is low. Accordingly, if a thionamide is needed during the first trimester of pregnancy, PTU is the preferred drug. So, its effects in lactation. Methimazole therapy does not affect thyroid function or intellectual development in breastfed infants, with doses up to 20 milligrams daily. Its preparation, dosage, and administration, therefore. Methimazole is supplied in tablets, 5, 10, 15, and 20, for oral dosing. For treatment of severe disease, doses are high initially, so 30 to 40 milligrams once a day, and then decreased for maintenance, back down to 5 to 15 milligrams once a day. As a rule, treatment continues for 1 to 2 years. When methimazole is discontinued, some 30 to 40% of patients remain euthyrotic, indicating remission. Others become hyperthyroid in 1 to 4 weeks, indicating a relapse. If relapse occurs, another round of methimazole can be tried. Alternatively, the patient can opt for radiation therapy or surgery. That brings us to PTU. Like methimazole, PTU suppresses synthesis of thyroid hormones and can be used for Graves' disease and other hyperthyroid states. PTU, a much older drug than methimazole, is now considered second-line treatment. It does contrast with methimazole. PTU is much like methimazole, but with 4 significant differences. The first being the most important. PTU can cause severe liver injury, whereas methimazole will not. Secondly, PTU has a shorter half-life than methimazole, 90 minutes versus the 6 to 13 hours, and therefore requires 2 to 3 doses daily rather than just the 1. Third, PTU crosses the placenta less readily than does methimazole. And fourth, PTU blocks the conversion of T4 to T3 in the periphery, whereas methimazole does not have that issue. So, current rule in treating hyperthyroidism. Because PTU is more toxic than methimazole and requires more daily doses, methimazole is the preferred route for most patients. However, there are three groups of people who will be, prescribed PTU because it's more preferential. The first being pregnant women, but only again during that first trimester. After the second and third trimester, it is safe to give methimazole. Patients experiencing a thyroid storm, again, because PTU can block the conversion of T4 to T3, it actually may be more effective than methimazole. And lastly, any patient who's actually intolerant to methimazole. Leading us to its pharmacokinetics. PTU is rapidly absorbed after oral administration. Therapeutic actions begin within 30 minutes. Plasma protein binding is moderate, 75 to 80%. The half-life is short, about 90 minutes, and hence PTU must be administered 2 or 3 times a day. Transplacental passage is low, as is its entry into breast milk. But again, it comes with adverse effect, and we touched on those already briefly. As with methimazole, adverse effects are relatively rare. Nonetheless, severe adverse effects can occur, especially in liver injury, as well as agranulocytosis. The most common undesired side effect, however, is a rash. PTU may also cause nausea, arthralgia, headaches, dizziness, and paresthesias. Adverse effects that share both methimazole and PTU, caused rarely, but most cases are the agranulocytosis, and can cause hypothyroidism if the dosage is too high. So both can have that issue. Again, in addition, PTU can harm the developing fetus and the breastfeeding infant. So due to its risk for liver injury, it has a big fat black box warning. PTU has caused rare cases of severe liver injury. Transplants have been required, and deaths have occurred. Liver toxicity is unrelated to dosage or duration of treatment. Furthermore, onset is sudden and progression is rapid, and therefore performing any kind of routine test for liver function doesn't even help because it's still not detected. So it's preparation, dosage, and administration. PTU is available in 50 milligram tablets for oral use. Because of its very short half-life, PTU requires multiple daily doses. For its treatment, for instance, in Graves' disease, high doses of 100 to 300 milligrams 3 times a day are usually initiated. Then lower doses of 50 milligrams 3 times a day are used for maintenance. As a rule, treatment continues for 1 to 2 years. So, patient-centered care across the lifespan. A good spot to look at a different lifespan of different patients and its use for its thyroid drugs. Which brings us slowly to alternative routes, such as your radioactive iodine. Physical properties. Iodine-131 is a radioactive isotope of stable iodine that emits a combination of beta particles and gamma rays. Radioactive decay of iodine-131 takes place rapidly, with a half-life of 8 days. Therefore, after 56 days, or 7 half-lives, less than 1% of the radioactivity in a dose of iodine-131 remains. So you can use it in Graves' disease. Iodine-131 can be used to destroy thyroid tissue in patients with hyperthyroidism. The objective is to produce a clinical remission without causing complete destruction of the gland. Unfortunately, delayed hypothyroidism due to the excessive thyroid damage is frequently a complication. Its effect on the thyroid, therefore, like stable iodine, iodine-131 is concentrated in the thyroid gland. Destruction of the thyroid tissue is produced primarily by emission of beta particles. The gamma rays from iodine-131 are relatively harmless. Because beta particles have a very limited ability to penetrate any type of physical barrier, they do not travel outside the thyroid. Therefore, damage to the surrounding tissue is usually very minimal. The reduction of the thyroid function also is gradual. Initial effects become apparent in a couple days to several weeks. Full development, however, does not show until 2 to 3 months. Not all patients respond satisfactorily to a single treatment. About 66% of patients with Graves' disease are cured with a single exposure to iodine 131. Others, however, require 2 or more treatments. So there are, again, advantages and disadvantages of iodine 131 therapy. So in the pro column, which are considerable, it is a relatively low cost. Patients are spared the risk, discomfort, and the expense of a thyroid surgery. Death from 131 treatment is relatively rare, and no tissue other than the thyroid is technically injured. Treatment with iodine 131, however, is not without its drawbacks. The first being, the effective treatment is delayed. It takes several months to become maximal. Second, and more importantly, treatment is associated with a significant incidence of a delayed hypothyroidism. Hypothyroidism results from excessive dosage and occurs in up to 90% of patients within the first year after the exposure of iodine 131. So you can almost assume that that half-life is probably longer to some extent. So who should be treated and who should not? Iodine 131 is indicated for adults with hyperthyroidism, as well as a patient who have not responded adequately to antithyroid drugs or to a subtotal thyroidectomy. As a general rule, young children are not considered, and it's inappropriate to consider them. The likelihood of delayed hypothyroidism is so high, and it's much higher than in that of adults. Also, there is a concern that the administration of iodine 131 to young patients may carry a slight risk for cancer. It should be noted, however, that there is no evidence that the use of iodine 131 in Graves' disease has ever caused cancer of the thyroid or any other tissue. Although iodine 131 is generally avoided in young children, it is commonly used in the post-pubertal adolescent and young adult. Iodine 131 is contraindicated in pregnancy and lactation. Again, exposure to a fetus of iodine 131 after the first trimester may damage the immature thyroid, and exposure to radiation at any point in a fetal life carries the risk for the generalized developmental harm. Accordingly, a negative pregnancy test is required before giving iodine 131. Also, because iodine 131 enters breast milk, women receiving this agent should not be breastfeeding. So, its dosage. Dosage of iodine 131 is determined by the thyroid size and by the rate of thyroidal iodine uptake. For Graves' disease, the usual range is between 4 and 10 milliseries, or MCIs. For the use in thyroid cancer, iodine 131 can be used to destroy malignant thyroid cells. However, because most forms of thyroid cancer do not accumulate iodine, only a small percentage of patients are candidates for iodine 131 therapy. The doses of iodine 131 used to treat cancer are large, ranging anywhere from 50 to 150 MCIs. These doses are much higher than those used for Graves' disease. Because high amounts of radioactivity are involved, body wastes must be disposed of properly. In addition, adverse effects from large doses of iodine 131 can be severe. They can include radiation sickness, leukemia may be produced, and bone marrow function may be depressed, resulting in a leukopenia, thrombocytopenia, and anemia. Fortunately, these severe effects are again relatively rare. It can be used for diagnostic use. Iodine 131 can be employed to diagnose a variety of thyroid disorders, including hyperthyroidism, hypothyroidism, and goiter. After iodine 131 administration, the thyroid is scanned for uptake of radioactivity. The amount and location of iodine 131 uptake reveals the extent of thyroid activity. Doses for diagnosis are minuscule, so usually less than 1 microcurie for children and less than 10 for adults. These tracer doses pose virtually no threat to health. Again, please note that although iodine 131 can be used for diagnosis, the preferred isotope is actually iodine 123. Its preparation, therefore, iodine 131 is supplied in capsules and solution for oral administration. Both preparations are odorless and tasteless. Capsules contain between 0.75 and 100 mCis of iodine 131. Vials of oral solution contain between 3.5 and 150 mCis. There also is the non-radioactive iodine, also known as the Lugol solution. So, how do we describe it? Well, the Lugol solution is known as a strong iodine solution. It is a mixture containing 5% elemental iodine and 10% potassium iodide. The iodine undergoes reduction of iodide within the gastrointestinal tract before it gets absorbed. Its mechanism of action. When present in high concentration, iodide has a paradoxical suppressant effect on the thyroid. Three mechanisms are involved. First, high concentrations of iodide decrease iodine uptake by the thyroid. Second, high concentrations of the iodide inhibit the thyroid hormone synthesis by suppressing both the iodination of the tyrosine and the coupling of the iodinated tyrosine residues. Third, high concentrations of iodine inhibit release of the thyroid hormone into the blood. All three actions combine to decrease circulating levels of T3 and T4. Unfortunately, the effect of iodide on thyroid function cannot be sustained indefinitely. With long-term iodide administration, suppressant effects become weaker. Accordingly, iodide is rarely used alone for thyroid suppression. It does, however, have its own therapeutic use. Strong iodine solution can be given to hyperthyroid individuals to suppress thyroid function in preparation for a thyroidectomy. Initial effects develop within 24 hours. Its peak effects develop in 10 to 15 days. In most cases, plasma levels of thyroid hormone are reduced with methimazole before initiating strong iodine solution. Then, strong iodine solution is administered for at least 10 days before surgery, usually along with PTU. In addition to its use before a thyroidectomy, strong iodine solution is employed in thyrotoxic crisis. Again, all good things have some adverse effects. Chronic ingestion of iodine can produce iodism. Signs and symptoms include a brassy taste, a burning sensation in the mouth and throat, soreness of the teeth and gums, a frontal headache, coryza, which is the inflammation and sneezing, salivation, and various skin eruptions. However, all of these fade rapidly after iodine use stops. You can actually overdose on iodine, which is a corrosive. So, overdose will injure your GI tract. So, your signs and symptoms of an overdose obviously will include GI symptoms, abdominal pain, vomiting, and diarrhea. Swelling of the glottis may cause asphyxiation. Treatment consists of a gastric lavage to remove iodine from the stomach and by giving sodium thiosulfate to reduce the iodine to iodide. Dosage and administration, therefore. When employed to prepare hyperthyroid patients for thyroidectomy, strong iodine solution is administered in a dosage of 5 to 7 drops, 3 times daily for 10 days, immediately preceding surgery. Iodine solution should be mixed with juice or some other beverage to mask its unpleasant taste. The dosage for thyrotoxic crisis is 10 drops every 8 hours. Which brings us to the last section here. Beta blockers. Propranolol and other beta blockers can suppress tachycardia and other symptoms of Graves' disease. Its benefits derive from beta adrenergic blockade, not from reducing any kind of levels from T3 or T4. One advantage of beta blockers is that they work quickly, unlike PTU, methimazole, or iodine 131. Dosages for hyperthyroidism are highly individualized. Beta blockers are also beneficial in thyrotoxic crisis. In the absence of contraindications, so your asthma or heart failure, all patients should receive one immediately. Administration may be oral or IV. The dosage for propranolol is 10 to 40 milligrams PO every 6 to 8 hours, or 0.5 to 1 milligram IV repeated every 4 hours until the effects are observed. The basic pharmacology of beta blockers is discussed in chapter 47. And I will add one last thing of note. You want to make sure that the patient doesn't have asthma or heart failure because beta blockers are beta adrenergic and they are non-specific, so they can cause bronchoconstriction. So that's your fun little fact for the day. I thank you as always for listening and for being part of the stream here, and I'll see you all at the next chapter. Till then, I thank you and have a wonderful day. Goodbye. Test, test. Okay.